Good morning, all. So you've heard some great scientific talks. This is not going to be one of those. I'm a nephrologist and a medical toxicologist, and I'm going to give you a clinical talk on nephrotoxins. Some that we give to patients in terms of therapy, and some that patients give to themselves. And as a disclaimer, there's fantastic data throughout much of this conference with thousands of patients, randomized controlled trials, meta-analyses. Toxicology literature isn't like that. Toxicology literature is case reports, case series, and if you're really lucky, maybe a non-blinded clinical trial. So nephrotoxins are fairly diverse, but just quickly, the way I think about it is that while some drugs directly injure the kidney, a number of compounds can become nephrotoxins in the right context, such as those given with other agents, or even drugs that we give to patients that are not nephrotoxic in and of themselves, but say like the vehicle that IV voriconazole is packaged in can be nephrotoxic themselves. And I won't go through these mechanisms, which were detailed well yesterday by Dr. Ferrari and others, but rather jump into a few nephrotoxins which are newer, or if not newer, have risen to more prominence in the last few years, just to give you a bit more detail on several of these. So to start with checkpoint inhibitors, immune checkpoint ligands are basically antigens which protect our cells from T cell destruction. In other words, they're involved in immune tolerance. Those cells that express them aren't destroyed as much by T cells, and unfortunately a number of tumor cells have learned to express these ligands. If they're present, such as CTLA4, PD1, PDL1, and a few others, they inhibit T cell responses, protecting tumor cells from the immune response, which normally will bump them off. But checkpoint inhibitors are drugs which act as antibodies to these ligands, removing that response and allowing tumor cells to be destroyed. But unfortunately, as you might imagine, when you decrease immune tolerance, you also target normal tissues as well. These are some of the more common effects which are seen with checkpoint inhibitors outside of the kidney. And I can tell you that virtually every patient will get a rash, and some of these are mild, and some of these, like pneumonitis, can be life-threatening. As far as the kidney goes, this tends to be a non-allergic interstitial nephritis, exactly what you'd expect from T-cell damage to tissues, where about 10 to 30% of these patients who are on checkpoint inhibitors with the best data we have available will be expected to develop acute kidney injury at some point during their course. And it tends to be either interstitial nephritis or granulomatous interstitial nephritis, although there are some cases of thrombotic microangiopathy or even glomerular diseases such as minimal change. They sort of respond to steroids, with the caveat that if you treat a patient with steroids and you don't have a positive response, that data may not always be published. So I always view steroid case reports and series with a bit of a grain of salt. That being said, what has been published suggests that patients are more likely to have partial improvement than complete recovery. And these tend to be high doses of steroids that patients are treated with, not simply 1 milligram per kilogram of prednisone. But I want to make the suggestion that as far as checkpoint inhibitors go, maybe, although I know that this is a conference on critical care nephrology, maybe the kidney isn't the most important organ here. These are drugs which are used to treat tumors such as malignant and metastatic melanoma that laugh at chemotherapy, laugh at radiotherapy, and have had good responses. But they're high-risk, high-reward therapies where many patients had to stop due to toxicity. And the toxicity that most oncologists fear most are pneumonitis and cardiomyopathy, because those tend to be life-threatening. To some extent, It's less stopping the therapy if you necessarily have acute kidney injury, but looking at the clinical picture and trying to mitigate it as much as possible, rather than stopping all patients' therapies when they have AKI. We're all familiar with vancomycin. Some of us may have practiced in the era, I did not, back when vancomycin was referred to as Mississippi mud in the US because of the contaminants which gave it a dark discoloration. And these contaminants, historically teaching, at least the way I've been taught and the literature that I've read in the past, are often thought to have accounted for much of the ototoxicity and nephrotoxicity of the drug, with the more purified versions being less likely to cause these. But, unfortunately, I don't think that's actually true. If you look at the historical acute kidney injury risk of vancomycin versus the risk of AKI from more recent case series, you see that the risk of AKI seems to be rising. And part of that is probably due to who is receiving vancomycin, patients who are sicker, patients who have pre-existing chronic kidney disease, but also we're using more and more vancomycin over time. If you go back to the 1980s and read the reports of vancomycin, that you'll see sentences such as it's accepted that 5 to 10 milligrams per liter is the trough that you're shooting for. Nowadays, it's 10 to 15, or more commonly 15 to 20. And if you have a patient with osteomyelitis who's getting this treatment for 6, 8, 10 weeks, that's a lot of vancomycin to be exposed to. What's come up more in the last 5 years is an increasing recognition of the danger of vancomycin and piperacillin tazobactam, where patients who are treated with both vancomycin and piperacillin tazobactam, which is not an uncommon combination, are more than twice as likely to develop clinically significant acute kidney injury in a variety of settings. These compared to vancomycin alone, the risk is fairly high, and compared to vancomycin plus other beta-lactams, that risk is still robust. And the question is, well, is it simply the beta-lactamase inhibitor that's causing the issue? Well, it's not just any beta-lactamase inhibitor, in that pip-tazo, when compared to amsulbactam, had similar rates of acute kidney injury until patients had vancomycin added, where amsulbactam plus vanco did not have the same risk as pip-tazo. So perhaps there's something about piperacillin itself that increases vancomycin nephrotoxicity. Maybe it's mitochondrial toxicity with antibiotics. Maybe it's that the tazobactam and not amsulbactam leads to increased intracellular vancomycin, or maybe it's some other effect. But in the meantime, for patients who are at risk for AKI, who have kidney stress, or perhaps those who have AKI, it's worth considering whether another antibiotic regimen might be better. So the last thing to mention with vancomycin, I'm actually been asked a few times what I think about vancomycin removal via hemodialysis to treat acute kidney injury. Well, logic suggests, well, if you have a nephrotoxin and removing it may be benefit, there's very little clinical data to support that decision. Most of the data I've found which I would consider worth considering are still case reports, and they're older literature. But I actually base it personally on the risk of ototoxicity rather than nephrotoxicity, where levels greater than 80 are associated with fairly high risk of ototoxicity. And unfortunately, there aren't enough data in my mind to make the decision, when do you dialyze for AKI? It's somewhat of an individual decision point. So let's move from things we give to patients to things that patients give themselves. Spice, K2, Crazy Monkey, Scooby Snacks, Mr. Happy, these are all street names, and there are many others, for synthetic cannabinoids. I want to make the point, these are not cannabis, these are not marijuana. These drugs have affinities for the same cannabinoid receptors, CB1, but anywhere from 10 to hundreds of times the affinity that tetrahydrocannabinol does. and they're given in much higher quantities. So what you see is a clinical picture much more akin to amphetamines, cocaine, sympathomimetic, and serotonergic drugs, bath salts, aka synthetic cathinones, where you get patients with agitated delirium, tachycardia, hypertension, prominent hallucinations. These are drugs which have unusual structures. They don't really look like anything else that's out there therapeutically or not. And they're rotated every few months, where the drug manufacturers will attempt to stay ahead of countries' license of legal regulation. If a country takes several months to make a particular compound illegal, the drug manufacturer will change what they're making into something else, and they'll continue to rotate that. And what they make typically doesn't have rigorous clinical trial testing. They can also cause very unusual effects, such as vasospasm, leading to ST elevation myocardial infarction, leading to stroke, leading to other organ ischemia, as well as non-resolving psychosis, where patients may have psychosis or paranoia that does not resolve. So as far as AKI goes, these cause ATN without evidence of ischemia, without evidence of rhabdomyolysis or severe hypertension, what you'd expect from amphetamines or cocaine, and they may also cause AIN, where you can see mitotic figures, and you can see in this ATN on the left, or this patient with AIN on the left, you can actually see some peritubular capillaritis. And it's not really clear where these are coming from. It could be activation of the MAP kinase pathway. It could be activation of intracellular calcium flux. But just to go through very quickly, the mechanism by which these and other novel sympathomimetic agents, such as synthetic amphetamine derivatives, cause injury. This is a clinician's version of the mitochondria. Very simple. It has the electron transport chain, which pumps hydrogens into the intermembrane space. Those hydrogens go back into the mitochondrial matrix, make ATP. ATP goes out to cells. This is the exceedingly short version of what Dr. Bajwa said at a very dumbed-down level. If you have uncouplers, such as synthetic cannabinoids, such as salicylates, such as cocaine, such as other drugs, these open something called the permeability transition pore, which allow these hydrogens to go back into the matrix, not making ATP, releasing energy in form of heat, leading to lactic acidosis. If you understand this, you understand a lot of drug toxicity. And you also understand how bears keep warm in the winter and how babies can stay warm without shivering, as well as how amphetamines cause weight loss by making your metabolism less efficient. And this is the mechanism thought to underlie some of the ATN seen in synthetic cannabinoids. As far as AIN goes from synthetic cannabinoids, it's very hard to tell whether you should treat it with steroids. It's probably not allergic. These are very fast drug exposures. These are not drugs given over long periods of time. And I think that the jury is out as to whether steroids help. Most of you are probably aware that the United States is having an enormous opioid addiction epidemic right now. We've overprescribed opioids for years, and it's coming home to roost. And undoubtedly, you're aware that opioids cause acute kidney injury from a number of mechanisms, the most common being patients who have overdosed, come in hypotensive with ischemic injury, have rhabdomyolysis from pressure necrosis with pigment nephropathy, have bladder obstruction. But there may also be direct opioid toxicity to the kidneys. This is very, the data on this in terms of patients is very scant. I won't go through it extensively, but there have been a few cases of renal lipidosis in patients who chronically take methadone, and there are evidence, at least from neonates, that children born to mothers taking methadone have retardation of kidney growth. So it's possible that there's a direct or indirect opioid effect on kidney development or a nephrotoxic pathway that we're not aware of. And lastly, I don't want you to forget our ESRD patients taking opioids. They are, although they may not be at risk for kidney injury, they are at risk for buildup of toxic opioid metabolites, whether those like hydromorphone 3-glucuronide that cause agitation and seizures, or those like morphine 6-glucuronide, which can cause prolonged sedation. Ketamine, an NMDA receptor antagonist commonly used in ICUs and more commonly over time, as I've seen, it also has a growing amount of illicit abuse, particularly in East Asia and the Western United States, where patients who chronically use ketamine have been found to have chronic urinary obstruction, hydronephrosis, and bladder wall thickening, shrinking of the bladder. And this may be due to glycine antagonism, where glycine reduces bladder apoptosis in mouse models. Ketamine produces the opposite. It blocks glycine receptors and may result in urothelial changes and cause acute kidney injury through prolonged obstruction. These patients may have to self-cath for life after prolonged ketamine abuse over a period of months. Really, the only treatment is to relieve obstruction. And lastly, I wanted to leave you with one last group of toxins, which are deadly mushrooms, which clearly been around for thousands of years, but have really spiked in news reports in terms of the number of cases that have come up. And some of these mushrooms are specifically nephrotoxic, with populations moving from different places, as well as climate change, people not being as familiar with the mushrooms. We're seeing an increased number of mushroom epidemics where dozens, or in the case of Iran, 1,000 people were poisoned by deadly mushrooms. Most of these are mushrooms that make cyclopeptides, which are compounds that block RNA polymerase. If you can't make RNA, you can't make proteins, your cells can't live. These are concentrated and excreted in the kidney, and while they're most notorious for acute liver failure, they're also directly nephrotoxic. Patients who ingest these mushrooms are typically asymptomatic for over 6 hours, then produce severe cholera-like diarrhea where the toxin is absorbed into gut cells that have time to die, and then have acute liver injury, acute kidney injury, cardiovascular shock through myocardial and vascular cell injury, as well as other organ failure. You should also be aware of mushrooms such as Cordonarius aurelinus, which contain a compound called arelinine, which is a toxin which is similar to paraquat or diquat. It disrupts renal tubular protein synthesis, covalently bonds to DNA, and basically causes reactive oxygen species injury to the kidneys. This mushroom is very hard to treat because patients typically don't have symptoms until over a day after ingesting it. And these symptoms are characteristic thirst, polydipsia, myalgias. And patients, about a third of patients who are poisoned by these mushrooms develop acute kidney injury, typically over a week later. And half of those patients who do will not completely regain kidney function, and some of them may even progress to end-stage renal disease. To finish, how do you treat an undifferentiated overdose patient who comes in with acute kidney injury? First off, there's no evidence to suggest extracorporeal drug removal works for most illicit drugs because most of them are fairly lipophilic. If a drug is lipophilic, it's more in the tissues, it's more protein bound, it really can't be removed to any great degree. The tiny fraction of drug that's in the bloodstream and not bound to protein, removing that is unlikely to change a clinical picture. There are some drugs in which you may want to consider thrombotic microangiopathy. Your best resource for plasma exchange for thrombotic microangiopathy, your best resource for that are the ASFA guidelines for apheresis, and otherwise treat based on the clinical scenario. Lastly, I want to thank my UVA nephrology colleagues, as well as the Blue Ridge Poison Center in Virginia, where I work, plus the American Society of Nephrology, which supports me via grants.